What I'll try and do in the next 15 to 20 minutes is actually share some ideas on fluid management and AKI. And right at the outset, I can tell you I don't have a recipe for you to take home and follow to perfection, but hopefully give you some ideas of how to think about this issue. These are my disclosures. And when we look at fluid management and AKI, I think it boils down to a very simple question. We know that oliguria has been associated with worse outcomes, but we also know that fluid administration has been associated with worse outcomes. So we have a dilemma in front of us, and that is a balancing act as to when is fluid administration necessary, and then if so, how much should be given. So let's take this first aspect. Is oliguria bad? Now we know that this emerged from the initial definitions from the rifle criteria, KIN and KDIGO, all incorporated the same urine output criteria, but are they valid? And yes, we have evidence to this with respect to multiple studies, including some from us, which had shown both the duration and the number of episodes of oliguria were associated with worse mortality. And in addition, if you added oliguria to increases in creatinine versus having oliguria alone, you found that, yes, there was an association with worse outcomes. And these have been validated further in large studies. So this is from John Kellam's group, looking at a retrospective analysis of their ICU patients, showing that if you looked at patients who were classified as having oliguria alone, serum creatinine elevation alone, or both, you found that there was a mortality difference across the board in contrast to those patients who did not have AKI. So at this point in time, I think it's pretty clear that we all agree to a large extent that oliguria is not a good thing to have. The other side of the coin is that if you give fluid, we've seen patients who end up like this. And we also know that we have a significant increase in fluid accumulation, which is quite common in the ICU, which contributes to edema everywhere. And multiple studies have been demonstrated, regardless of the underlying etiology, that fluid accumulation is contributing to or is associated with worse outcome and mortality, and that this phenomena, as shown here, has been seen also independent of both the fluid accumulation, so this is the mean fluid balance in survivors, non-survivors, versus the mean urine volume. So despite the use of diuretics or no diuretics, you find that there is a correlation between these two. So that now poses the question is, if oliguria is bad, but fluid accumulation and fluid resuscitation is also harmful potentially, what should we do? And therefore, this asks the question is, should we give fluid to correct oliguria? And to understand this to a large extent, one of the more important things is to just revisit renal physiology, which almost all of you are very familiar with, but just to re-understand the intricacies with which this happens. To make this a simplistic thought process, you've got three processes. You've got filtration, you've got salt and water handling, and urine flow impediment as three possibilities downstream. Now, what we know from several studies, both from humans and from experimental models, that you obviously need a pressure gradient within the glomerulus to be able to make urine. Now, that pressure gradient is therefore dependent on both the mean arterial pressure, but to a large extent is also dependent upon the intraglomerular pressure, what happens within the glomerulus itself. Now, when you take this into context, you see that the efficiency of a nephron to filter is dependent upon what is the opposing pressure based upon as you filter protein-free fluid, the oncotic pressure starts rising, and as soon as that pressure gradient is maxed out, you stop filtering. So depending upon whether you have a normal capillary or you have a reduced capillary length, you have this part of the nephron, each glomerulus is contributing to the filtration part itself. A second phenomenon, which you're all very familiar with, is the autoregulatory range. And what that means is that within a tune of a certain glomerular blood pressure range, you can maintain a glomerular filtration rate. Now, why then, how does that occur? Is simply by modulating the afferent and efferent tone. So essentially, in response to different phenomena, you will have afferent and efferent tone, which changes the intraglomerular pressure and therefore the ability to make urine. Now, why has this become very important? As Ronaldo and others have shown more recently, you can see that renal blood flow can be maintained, but your GFR will go down depending upon if you've got efferent vasodilatation or you have efferent vasoconstriction to maintain your GFR. So essentially, depending upon the tone in the afferent and efferent, you can manipulate it. So the first principle, therefore, for oliguria is your filtration fraction, and the amount of urine you make is the pressure gradient maintained. So the second aspect of this is probably even more important to a large extent, is that after filtration, what happens to urine. Now, in all mammals, we have two kinds of nephrons. And those are those which are the cortical nephrons, which have got this loop of Henle, which goes just till the outer zone of the medulla. And this is about 85% of nephrons in the human. And about 15% of them have these juxtamedullary nephrons, which go really deep down. Now, these nephrons are therefore responsible for both the ability to concentrate and dilute the urine, and as you can see, this is maintained by creating a gradient within the interstitium around it so that you have absorption of water in the descending limb, and then in the ascending limb, which is impermeable to water, you can dilute the urine, and in the collecting duct, under the influence of ADH, you can reabsorb water in that setting. Now, with that principle, one of the key things which comes into importance here is if you look at comparative physiology, is that the adaptation to humans depends upon what environment you're in. So a beaver, which is living mostly in water, has access to water all the time, has a different loop of Henle characteristic than a rabbit versus a kangaroo rat, which is a desert rat. Now, this animal lives predominantly in hot environments, and therefore the loop of Henle therefore becomes very important in this animal to be able to concentrate the urine. So the deeper the juxtamedullary nephrons are, the more you're able to concentrate the urine, and as you can see, this particular animal therefore has the ability to concentrate its urine and therefore make do with very small amounts of water. Now, what that leads to, therefore, is this difference. If you take a cow versus a kangaroo rat, you can see that the water loss here in a cow is predominantly from urine, feces, and evaporation, whereas in the kangaroo rat is predominantly evaporation, very little urine is necessary. So to a large extent, teleologically and functionally, our nephrons are structured in such a way that we don't necessarily need all the nephrons in play, depending upon where we are. So in humans, we make about 1.5 liters of urine. We have a very small amount of evaporation on usual days when you're air-conditioned like this. But if you're out in the hot environment, this segment starts becoming bigger and the urine output starts becoming lower. So it depends upon our ability to regulate our volume is an integral functional component that we all are blessed with. Now, the last part of this is that when you have obviously severe AKI and everything is shut down, certainly no urine is forming. But to a large extent, when you get to this phase, it's a very different phase than what most of us are tuned to seeing in AKI itself. So when you think about these three components now, all contributing potentially to oliguria, you have to realize that we've got some physiological responses which are designed to able to conserve water, and that causes oliguria, versus is the oliguria pathological because of an injury that you're unable to put those conservative mechanisms into play. So if we think along those lines, so then the next step is, can we determine what is causing the oliguria? Now, in order to do that, the first aspect here would be is to just recognize is what is our normal fluid balance from. You can see in homeostasis, you've got inputs and losses which are matched, and to a large extent, our intakes are from fluid intakes and water from food. But what we don't realize to a large extent is some of the water we make is from metabolic products itself. So as we burn carbohydrates, lipids, and proteins, water is generated. And that water is also contributing to our intake itself. Now that's very different from our usual assumption that everything we eat is only, the water we take is the only way we're getting it in. Now, one of the most important aspects of this is that we all form urine only based upon the need to excrete solutes. If we didn't have any solute intake, you probably wouldn't need to make as much urine. And that's exemplified by this. So if your total solute intake is 400 milliosms, and you've got the maximum concentration capacity of the kidney, you only need 300 mLs of urine. If you take the same amount and you're taking 12,000 milliosms, at the maximum you'll need 0.9, but you can see the urine volume increases the more the solute load. So at any given point in time, your ability to form urine, even with normal renal function, is driven to a large extent by how much solute you take in. If you have no solute to take in, you will not need and will probably not form as much urine itself. Now, with that in mind, another key principle, obviously, then, is this osmoregulatory aspect that we are blessed with. Essentially, as the tonicity of fluids in our plasma goes up, you have an increase in ADH. This is also stimulated by baroreceptor function overall. And as tonicity goes down, you shut ADH off. This mechanism is quite unique in humans. In most animals, they have a thermoregulatory mechanism in addition to osmoregulation, which comes into play. Now, why is this important? Because if you think about it, the three ways that we can manifest our water mechanisms is renal regulation, thirst and drinking behavior, and sweating. Those are the three things that we have overall to be able to manage this. And when you look at sweating as a way, you can see this largely depends on what activity and what intensity it is and how much what this sweating rate comes into play. Now, when we did a large population-based study across the world and looked at this with respect to what were the presenting symptoms of patients who were identified as acute kidney injury, we found to a large extent they were dehydration, infection, and urinary symptoms, which meant usually oliguria in this setting. But when you think about dehydration, our thought about that term is very dependent upon what connotation we put it into. And by definition, dehydration can be three types. You can have isotonic, which is a balanced loss of solutes in water, a hypotonic, when the sodium is lost at a greater rate, water resulting in serum sodium concentration less than 135, and hypertonic, where the water losses are more than this. Now, this is predominantly what you see with sweating, because sweat is hypotonic itself. And this is also seen in the elderly, where the muscle mass is a lot less and the water content is less, whereas here you will see this more in terms of diarrhea. So what you can see here is isotonic is gastrointestinal fluid losses, hypotonic is sweating, diuretic drugs, or hypotonic is sweat with high sodium content in this setting. Now, in a study which was done in malaria patients, you can see this is about almost 1,200 patients. You can see that the presenting patient components here was vomiting, and diarrhea were for those patients who had mild versus severe AKI. So this is an example of essentially a isotonic loss. If you take healthy recruits in the US Army and you study them with respect to when you have hypohydration after severe exercise, what you start seeing is the plasma osmolality goes up and the plasma volume goes down. With that severe exercise. This is the normal conditioning aspect of this. And what that ends up doing is this hypertonic dehydration sets into motion ADH secretion and reabsorption of water overall, and the changes inherent to that so that you are reducing your urine volume to accommodate those changes in osmolality. Now, what I'd like to show you here is these two very disparate animals. And you would ask yourself, why am I showing you this? Because this 200 kilogram or bigger animal and this 30-gram little frog share between them the same complexities of adaptation to environmental stress. And that is that both of them undergo hibernation for long periods of time. And during that hibernation, they're totally anuric for 6 months. They make no urine. And when you ask the question is, how do they survive? They do this year in, year out. This little frog gets buried in the snow and is frozen like a popsicle. And this bear goes to sleep for 6 months. And when people have studied these two, and this is in bears, what you find is that the bear has a urea level which doesn't go up. The creatinine level does come up in the winter, but after the winter, it comes back to normal. And what is happening is making no urine. And what's happening is the urea is being recycled into protein. All the carbohydrates that the bear ate during the summer is being metabolized, and there's no loss of muscle mass. Nothing happens to the calcium. Nothing happens to any of the bone structures. The bear lumbers around in the same way. Now, in contrast, so this is what happens to the bear. You can see here, summer versus winter, the creatinine goes up, the urea stays down. In contrast with the frog, which is going through the same issues to a large extent, this is the seasonal variation you've got through November, December. This is where the frog is likely to be frozen. And you can see what happens here is the osmolality goes up, the body water goes down, and then as your hydration occurs, it goes back down itself. So this high osmolality is very protective for this particular frog, because what it does, it allows cryopreservation. It allows the organ systems to be preserved, and you can see in the hydrated versus the dehydrated, the osmolality is significantly higher overall, and look at what the sodium is doing from 120 to 189 in that setting. So I make this point here just to say is to a large extent we are equipped with an organ with senses and is able to manage a lot of fluid shifts itself, so that it's very important for us to recognize that these changes are going to happen overall. Now take, for example, this very nice study which is from Peter McCullough looking at marathon runners. So in this particular study, they actually took these marathon runners, 25 of them, and studied them immediately after a marathon run and 24 hours after. But not only did they do all the regular things, they also did a cardiac MRI, so they were able to look at heart performance and also other parameters itself. And what they found was, here's what happens is the serum creatinine goes up after a marathon run, and 24 hours later, it's back down to normal. And you can see that this is the serum cystatin C, which tracks it in the same way. NGAL goes up in the same way, KIM1 goes up, and they both come back down in recovery overall. But what ends up happening here is when you look at their parameters overall, you see that there's no significant difference in the sodium, but the potassium levels are much higher immediately after this part itself. And when you look at the urine-specific gravity, they didn't have it in the immediate post, largely because they were not making as much urine at that point in time. So it just shows you that these parameters, this normal fluctuation in terms of urine changes, are part of our daily life. So in order for us to react and respond to this, we need to be cognizant of the fact is what is physiological versus what is pathological in this setting. And when you think about it this way, clinically, we need to think about what is predominant salt depletion versus water depletion and have a systematic approach to this part. And there are obviously indices for hydration which are there, but we have not really utilized them as efficiently as we should in this setting. Amongst the urinary parameters, we do focus on urine electrolytes, but I can tell you we do not have a standard approach to using this in every patient. To a large extent, we either rely on them sometimes or we don't rely on them, and that's why the literature is fraught with saying is whether they are valuable or not at this setting. So my final question to you, and my answer to this question would be, should we push fluids? Now, there's many studies, and subsequent speakers will be covering them, so I started to focus only on just one of them. And this is a figure from a very nice recent article from Michael Ioannidis in Intensive Care Medicine, representing the classic trial, which is just exploring the classic trial, which was looking at patients who were giving a fluid-restricted or a standard approach for resuscitation. And you can see that there is no change in urine output with the restricted approach. But what is more interesting is that worsening of AKI was seen predominantly in those patients who got standard care. So it's not necessary to give lots of fluid for every patient with AKI itself, but what we do need to understand is that when you're giving fluid, you have to ask a question why you're giving it for what aspect of it, and overall, when you think about the recommendations which come in, probably the most important recommendation is that oliguria is a normal response and should not be used solely to trigger fluid. So every time we think somebody's got pre-renal, doesn't mean we have to give them fluid in that setting itself. And therefore, a clinical approach to this problem is probably the more relevant way to look at it. And more importantly, if you do want to give a fluid challenge, if they think is hypovolemic, it's 250 mLs over 30 mLs, and then after that is to watch the response and not give too much more. So my last slide here is, I think, to answer this question, these are just thoughts for your approval, for your consideration. I don't have a clear recipe for it because I think each individual has to be treated as an individual. We have to recognize that we do have physiological variation which comes into play. And I'd like to invite you to this meeting, which is in Malaysia, and also the next one in San Diego. Thank you for your attention.